or good afternoon. Thanks for joining. There's a lot of information on this topic on the CMS website. It can get quite overwhelming. So my goal with this presentation was really just to summarize and give everyone a straightforward, view of what's required and give resources so that if there's anything that you need to dig deeper into, you can do that using the CMS resources. So I know not many people have time to go and dig around on the website through hundreds of documents. And we may do future presentations on certain aspects of this, so to dig a little deeper into this. So if you feel that may be helpful. So here is our disclaimer statement, and it's just saying that at the time of this presentation, it is intended to be a general overview and it's current at the time of the presentation. So we do encourage you to keep up with the rules and regulations to stay the most up to date on this information. So on our agenda today, we have the goal of the radiation oncology model, the reasons for reform, types of participants, RO model design and pricing methodology, participant requirements, and quality measures and clinical data elements. So let's jump into the goal of the radiation oncology model. And the goal of this model was really to see if prospective episode-based payments for radiation therapy episodes of care would reduce Medicare program expenditures and preserve or enhance the quality of care for Medicare beneficiaries. So CMS believes that a simplified, predictable payment system would offer participants the opportunity to examine and better understand their own processes and patterns, which would lead to an opportunity to redesign the care and improve the quality of care for the patients. So just a little background on this. This has been in CMS's focus since 2014. They've been trying to explore potential ways to test an episode-based payment model for radiation therapy. December 2015, Congress passed the Patient Access and Medicare Protection Act, which required the Secretary of Health and Human Services to submit a report to Congress on the development of an alternative payment model for radiation therapy. And that was published in November of 2017. So of course, implementation was delayed due to the public health emergency. The act actually required that the model addresses radiation therapy in a non-facility setting, which would be a freestanding radiation therapy center. But after research, they found that most of the time, 62% of the time, radiation therapy is actually provided in a hospital outpatient department. So they decided to expand it to hospital outpatient departments as well. That way, everybody's billing the same and you don't have that difference, different billing from site of service. So now we're going to look at some of the reasons for reform. There's three key reasons why radiation therapy is ready for payment service and reform. And one is the lack of site neutrality for payments. So basically, with our current way of billing, where the patient has services provided determines how their payment rate is set. So you have that site of service differential because different payment methodologies are being used. So this also creates incentives for one setting to be used over another. Secondly, we have incentives that encourage volume of services over the value of services. Because other payment methodologies are used, and the ones that are used are resource-based systems currently, higher payment rates are assigned to services that use more expensive equipment or higher volume of patients. Research shows that this may encourage the use of certain modalities over others, which could be problematic if the incentives don't align with your evidence. So you can see how that would be an issue. And the third is your coding and payment challenges. And anytime you have the exact same services being billed in different ways across sites, you're going to have your coding and payment challenges. And we're going to go over more detail of this in later slides. So modern radiation therapy is generally furnished in two different sites of service. You have your hospital outpatient departments, which is referred to as your facility settings, and your freestanding radiation therapy centers, which is your non-facility settings. And then, as I stated before, the site of service determines how it's paid, and that is your site of service differential. So, for example, hospital outpatient departments, your technical portion is paid under hospital outpatient prospective payment system, which is your OPPS system. If I know most of you probably have knowledge on these different ways of billing, but I'm just going to do a brief overview for those who don't. So with your OPPS system, you have ambulatory payment classification groups, which is APCs, and they group all procedures that are clinically similar and that are in regard to resource consumption. Those are grouped under one APC classification, and they're all paid the same. For radiation therapy, the APCs are organized into two series. You have a level 1 through 3 for your treatment preparation and levels 1 through 7 for your treatment delivery. And then these series go from a lower cost to a higher cost while still maintaining the clinical coherence for the services assigned within that APC. So your freestanding radiation therapy center, the technical portion is billed under your Medicare physician fee for service, PFS. And your RVUs is the primary determinant of payment rate. So for this payment system, the RVUs, which is your relative value units, is divided into 3 parts. You have your professional work, your practice expense, and your malpractice. For the technical piece of radiation therapy, the practice expense is the primary determinant. This relies heavily on voluntary submission of information, and CMS has explained that they have very few means to validate the accuracy of this information. So mostly for the expensive capital equipment, they can't find a consistent and reliable way to validate the cost. So because there's so much growth in technology in this area, these codes are misvalued in a lot of cases, which is just horrible for providers who are providing this care because they're not being paid accurately. So you can see how these payments would be misaligned between OPPS and PFS. So moving to number 2, for both hospital outpatient departments and freestanding radiation therapy centers, the professional portion is paid under PFS currently. In hospital outpatient departments, you do have a small percentage that's paid under the inpatient prospective payment system through using the MSDRGs. This is only for inpatients. And then both sites of service do use the common procedural terminology, CPT code set. So now we're going to look at the types of participants that are required to participate. So CMS determined participants by randomly selected stratified core-based statistical areas, also called CBSAs. These areas had to have a population of at least 10,000, and they had to have a high degree of social and economic integration with the core, which is an example like an urbanized area or an urban cluster. The CBSAs had to be large enough to capture relevant markets and referral patterns. They felt that these areas would capture the diversity of the radiation therapy providers and suppliers best. So they wanted to make sure that they had a really well-represented sample to see how the model works across the board. The zip codes required to participate can be found on this website provided. If you see that you are required to participate, the first thing that you should do is contact CMS, Radiation Oncology Model help desk for your RO model ID number. That is your first step, and that will allow you to get into the portals where they explain how to submit things and stuff like that. One thing to note is that the participation zip code, it is the site of service zip code. So your billing address does not determine your participation. It is your site of service. It's where the services are provided. Another thing to note is that participants are excluded if they are a hospital participating in the PA rural health model, if they are a hospital participating in the community transformation track of chart model, if they are furnishing radiation therapy services solely in Maryland, Vermont, or US territories, or if they are ambulatory surgical centers, critical access hospitals, or PPS exempt cancer hospitals. Facilities participants can opt out of participating, but only if they have less than 20 episodes of care within a performance year for the previous year. So for this performance year, if you last year had less than 20 episodes of radiation therapy care, you could be eligible to opt out. If you think that you may qualify to opt out, you can see on the CMS website, there's instructions on how to submit an opt-out certification on the portal. And I have instructions later in the presentation on how to access the portal. So an RO participant can be a physician group practice, a freestanding radiation therapy center, or a hospital outpatient department. There's 3 types of participants. You have your professional participant, which is identified by a taxpayer identification number, and they only provide the professional component of the radiation therapy services. It's the technical component is identified by a CMS certification number or a TIN, and they only provide the technical component of the RT services. And then you have your dual participant, which provides your professional and your technical component. And an example of this would be like a freestanding radiation therapy center that provides both the professional and the technical component. And here's a chart just explaining what I just went over. It's just a little visual. To your left, you see your professional component, which is furnished by a physician. You have your technical component, which is not furnished by a physician. It's the provision of equipment, the supplies, personnel, and costs related to the radiation therapy. You have your professional participants, which is your physician group practice, and they submit the professional component. You have your technical participants, which is your hospitals or your radiation centers, and they submit the technical component, or you have your dual participants, which do both. So let's go over the model design and the pricing methodology. The basic design of the RO model includes several key elements. It is an alternative payment model, and payments are made by episode. So it's bundled payments, and you have your first payment being made at the start of an episode, 50% of your payment at the start of the episode, and then you have your second payment at the end of your episode. So your second 50% at the end of the episode. It is a site neutral model. So CMS has figured out a formula for making payments site neutral, and we're going to get into that on a later slide. It does get quite complicated. And then it's episode payments that are split into professional and technical. And the reason that they kept it split into professional and technical is so that they can compare these payments to the current billing methods. So they're going to compare how you would currently bill for a certain service compared to how you bill from the RO model. And you're going to have to turn in these claims that are not for billing, but for comparison purposes. And basically, they're going to use it as a check and balance. So if they see that it's not lining up, the payment's not lining up, that's an area of research they need to do, and that's something they need to look into. And then this model will link payment to quality, and I'm sure that's nothing new that you've seen. That seems to be the going thing now, linking your payment to quality, which is good. So, and then lastly, the RO participants are required to participate. So it is not an optional model. You can only opt out if you don't have enough episodes of care. One thing to note is that the RO model is not a total cost of care model. So this, unlike the oncology model, which is a total care cost of care model, The radiation therapy model is not. You still have to bill some things using your current method of billing. So if that's fee for service, that's what you're going to have to do. So you can see on the left, it has all the included services, which is your treatment planning, your technical preparation and special services, treatment delivery, and treatment management. On the right, you'll see that the initial consult, which is typically billed using an E&M service, that will have to be billed fee for service. Experimental and low volume treatments will have to be billed fee for service. General imaging or outpatient OPPS. General imaging that's not related to your radiation prep. Radiation therapy furnished at another setting. Radiopharmaceuticals, intraoperative radiation therapy, and then brachytherapy services. One thing that I just want to mention is that CMS does feel like brachytherapy should be included, but they were not able to include it in this performance year for some reason. So they are working on a way to include those services into the model. Okay, so there are only certain types of cancer diagnoses that are included in the model. For your other cancer diagnosis, you would bill your regular way of billing. So these are, at the top, you'll see the different cancer diagnoses that are included. Liver cancer was actually on this list until recently. They removed it due to the evolving evidence around the use of radiation therapy as a treatment. And you'll also see the modalities that are included here. So if you are not providing one of these modalities, if you're doing an excluded modality, so you're doing brachytherapy, that will have to be billed either through OPPS or fee for service. So also, any changes to these lists will be communicated by CMS no later than 30 days prior to the performance year. So as I mentioned in the previous slide, that the payment rate would be site neutral. The next couple of slides are going to go into detail on how these payment rates will be determined for each cancer type included in the model. So this is just a summary of 8 steps that CMS is going to use in its pricing methodology. This does apply to both your professional and your technical payments. So they've created base rates for professional and technical components for each cancer type. And the way they created these base rates is they used historical average costs for each episode of care based on fee-for-service claims from 2017 to 2019. You see this chart at the bottom of the slide. This is what this will be provided to you. This is actually on the CMS website right now. And it'll tell you which HCPCS code needs to be used for that particular type of cancer included in the model, whether it's the professional or the technical piece. And then it'll give you the trended national base rate and then divided by 2, because you have your first payment at the beginning of the episode and your second at the end of the episode. Now, one thing to keep in mind is that this is your starting point. All these other steps that I'm about to go over will be applied before this is in your payment rate for that service, because obviously different sites of service will have different payment depending on different things, which we're going to go over. So they're going to apply a trend factor to the base rates to reflect current trends in payment and treatment pattern changes. And so this accounts for volume and payment trends outside of the oral model using the OPPS billing method and MPFS. And they use recent claims to calculate this. They are going to apply geographic adjustments, and they're going to apply adjustments based on historical experience and case mix history. So your historical experience, it addresses differences in the facility's historical care pattern. So they're going to look at how you billed in the past for this type of treatment and take that into account. And then they're also going to look at your case mix history, which is how sick your patients were. And this is really very dependent on the documentation in the record and what has been coded. So you know, hopefully your case mix is accurate. If it was coded accurately, if it was documented accurately, then you should have no problem with this. And then let's go to the next slide. So then they're going to apply that discount factor. And then they're going to apply an incorrect payment withhold, which depends on three things. So the first piece of this is going to be determined during a reconciliation process. This reconciliation process is going to be done by CMS, and it's going to look for duplication of charges or incomplete episodes. And this will determine if a participant receives the withhold back or if they owe CMS money. So your incomplete episode is basically if you didn't meet some of the criteria, if you didn't do things in a timely manner, which we'll go over later. But there's several things. If your patient switched insurance, like if they went from Medicare to another insurance during treatment, that would be an incomplete episode. And then duplicate charges would be, you know, if the facility accidentally filed duplicate charges, or if the patient went to another facility and billed, there's different rules about what can be billed at another facility. So basically that's what they're looking for. And then they're going to determine if you will earn that back or if you owe CMS money. In performance tier 2, you're going to have your quality withhold, which is based on the performance and reporting of your quality measures, which we will go over later. And that's 2% of your payment. And then performance tier 3, the patient experience withhold will kick in. So that's going to be based on the CAPS radiation therapy survey. And then they're going to apply the beneficiary coinsurance. So beneficiaries will still have that 20% coinsurance, but they're going to have fewer and higher payments because of the nature of the bundle. So they're going to pay less, but they're going to have higher payments when they do pay. CMS does encourage providers to set up payment plans for patients, especially those that don't have secondary insurance. And then they're going to apply a sequestration adjustment in accordance with applicable law. So I want to just give you an overview of how the billing process is going to look for the RO model. This is for the professional component. Each RO model billing episode is going to be 90 days, and I'm just going to go through the steps. So for professional component, you are going to be required to bill at one of those RO model specific HCPCS codes that I showed you in the chart earlier with a modifier that will represent the start of an episode. And that modifier is V1. So once they receive that, they will give you your first half payment. Then the professional participant has to provide the technical participant with a signed and dated radiotherapy prescription and the final treatment plan. So this is going to inform the technical participant that the episode has begun. Because that technical piece, those services need to be provided within 28 days of that start of episode. So when the RO episode is complete, the professional participant will bill that same HCPCS code from the first start of episode claim, but this time they're going to use a V2 modifier, which is going to signify that it is end of episode modifier. So the end of episode claim, it can be submitted and paid as early as day 28 of the episode if you're sure that the treatment is complete, but you do have up to 90 days. So, but you cannot submit that earlier than day 20. You cannot submit your end of episode claim before day 20. And then once you submit that end of episode claim, CMS is going to pay your second half for the episode. We're going to go into more detail on this because I know it gets really confusing, especially when you start adding in the fee-for-service billing for items that are not included in the RO model. So here's the technical billing process, and it's very similar. One thing to note here is that even if the professional component has not been billed yet, the technical piece can be billed. Excuse me. So they do not have to wait on the professional piece to be billed before billing the technical piece. And it is the same process for the technical piece. You're gonna do your start of episode claim with the V1 modifier to signify your start of episode, and then you're gonna do your V2 to do the end of the episode. So again, the RO episode is 90 days. SOE is your start of episode. EOE is your end of episode. Your episode payments are made in 2 installments. The 50% at the start, 50% at the end. You will also have to submit encounter-like no-pay fee-for-service claims that need to be submitted after your initial SOE claim is submitted, and then before the end of the clean period, which the clean period is the 28 days after your end of episode, when all of the radiation therapy services not included in the RO model are billed. So basically, let's just go through this chart. So day 1, you have your initial treatment and planning service. They meet with the physician, you get your HCPCS code, you submit your start of episode claim with that HCPCS code and your V1 modifier. After that day, you can start submitting your no pay fee for service claims. So you can bill that E&M fee for service claim. Just to note, it has to be done on a separate claim. You cannot put your RO model claim with your V1 modifier, should not have anything else on it besides that HCPCS code and the V1 modifier. Your fee for service no pay claim has to be a separate claim. And then on day 28, by day 28, the patient has to receive those technical services. If they don't receive those services by day 28, it's going to be considered an incomplete episode, and CMS is going to revert it to fee for service. And then that'll also put you at risk for losing some of your payback money that I went over in the previous slide. So you really want to make sure that those services are provided within those 28 days. And then, so after that, you're going to, on day 28, if your patient is finished with treatment, you can submit your end of episode claim at that point, but you can't do it before day 28. So you can submit that claim, and then by days 90 through day 118, that's considered the clean period, and that's when they give you time to submit all your fee-for-service stuff that was not included in the RO model. So that would be like your, if you haven't submitted your E&M level yet, your brachytherapy, your pharmaceuticals, that would all be done during that time if you haven't already done it. So basically for these claims, these episode no pay claims, you can submit these at the frequency of your choosing. If it's easier for you to wait to bill all of that during this clean period at the end, do that. You know, if it's easier for you to do it throughout as you're doing now, you know, the current process that you have now, you can do it that way. The HCPCS codes that are on the start of episode claim and the end of episode claim are not the code you're going to use on your encounter-like no pay claims. You're going to continue billing how you currently bill using the same codes you currently use on those claims. So, I hope that explained it. It can get pretty complicated, but here's another way to lay it out in kind of like a simplified version. And it just goes through, you know, what needs to happen after your planning and your treatment. You attach your V1 modifier, and then you get your first half of payment. And then the white is your technical component. So just another way to look at it. Okay, so participant requirements. So professional and dual participant requirements will need to submit claims in accordance with the RO model billing instructions, meet applicable state and federal licensure certification requirements. They need to go into the Radiation Oncology Administrative Portal, also called the ROPE, and attest to a certified electronic health record technology. This is due at the end of January. And then they also need to review and revise an individual practitioner list, which is due at the end of the summer. This is available for you to do now. And I have the website here for instructions on how to access the portal, but you will need that model number that I talked about in the beginning of the presentation in order to access this. When you access the ROPE, one thing I wanted to mention is that look for something called RO Connect. It's a collaborative resource site for participants. And it's a way to connect with peers and ask questions and share knowledge. And there's also a lot of videos of different instruction on different things. So I think it's a really good resource. And so the next requirement is that report on quality measures by March of each performance year and clinical data elements in July and January of each performance year through the secure data portal. Or you forfeit your potential to earn back some of the quality withholding. So I also have instructions here on how to access the secure data portal. Okay, so these requirements are for our professional participants and dual participants. And for these requirements listed, it's not things that you need to submit to CMS. However, you should document it in some way in the chart or however you see fit. For in case CMS has like a random site visit or a virtual chart audit during the course of the RO model, they will check on these things. So, so these participants must ensure that individual practitioners discuss the goals of care with the patient and whether the treatment is, if the intent is going to be curative or palliative. Obviously, you need to adhere to national recognized evidence-based clinical treatment guidelines. If you don't, you would need to document in the medical record the rationale for this, for not. Assess each RO beneficiary's tumor node and metastasis, cancer stage for CMS specified cancer diagnosis. Assess the beneficiary's performance status as a quantitative measure determined by the physician, and then send a treatment summary to the referring physician within 3 months to coordinate care. So the next one is to perform and document a peer review. And so performance year 1, it would be 50%, performance year 2, 50% of your patients would be 55, and so on and so forth, as listed here. So your peer review is basically just going to be feedback from another provider. It can be in another practice. It can be from someone on the care team. And it should preferably be before the patient starts treatment, but they do require that it is done before 25% of the total prescribed dose has been delivered and within 2 weeks of the start of the RO treatment. So many of you already have existing peer review processes because it's required by some organizations, accreditation programs. CMS doesn't really go into detail about what's required here. They really leave it up to the facility. It's mainly just that you're getting feedback on the treatment plan. And they do have some things that you may want to include in the peer review, but it's not absolutely required. So they say that you may want to review the decision to treat with radiation therapy, the goal of treatment and the treatment approach, review of target values, review of prescription dose and dose constraints, review of overall plan quality. And then, they just suggest that you include physicians, physics, and other staff members of your treatment team. And it's just an opportunity for discussion and feedback, a peer review process. So it can be done in person or virtually, whatever is most convenient. They did say that You could put a templated note in the chart that says the peer review has been completed with the date, or you can have minutes from a peer review meeting with the patient chart numbers. Those are some ways you can prove that it's being done if you are to be audited. Okay, and then, so the next requirement is that it needs to be discussed with the patient prior to treatment, their inclusion in the RO model and the cost sharing responsibilities, that they'll have less frequent payments, but it may be larger payments at one time. And then all participants, all beneficiaries, patients, need to be advised that they will be part of the RO model. So I have a link here on where you can access the letter that should be sent out to anyone who will be affected by this. Any of your patients that will be affected by this. Is very easy. They have the letter drafted for you. You just fill in blanks on the letter and it auto populates. One thing to note is technical participants do not need to send this letter. This is only for your professional participants and dual participants. And then here are your technical and dual participant requirements. So you're just going to submit claims in accordance with the RO model billing instructions and do so applicable to state and federal licensure and certification requirements. Excuse me. One new thing is that before the end of a performance year, technical participants need to complete a patient safety organization attestation in the ROPE, which is the administrative portal. Okay, so CMS says that due to the public health emergency, there's been some exceptions and flexibilities intended for performance year 1, which is January 1st, 2022 through December 31st, 2022. So the quality measures and clinical data elements will be optional in performance year 1. So that's really awesome. You have another year to really understand what you need to submit. And because of this, the 2% quality withhold will not be applied. So they will not be withholding that 2% since it is not required. For the technical participants, the AHRQ listed patient safety organization will be optional. That's what I just talked about in the previous slide for technical participants. That will be optional in performance year 1. So that does not need to be done this year. And then the requirement for the peer review is also optional in performance year 1. So great news. So I'm sure everyone's asking, like, what is the point of doing the quality measures and clinical data element submission if it's not required? And CMS says it's a good process to get down, before it's actually required. It's good to practice. And that way, when it is required, it's nice and easy to go into. And also you can get feedback from CMS on if you're doing it correctly, what improvements can be made, et cetera, before it actually is required. So what's going to happen to you if you do not comply with all of this? So if you are not complying, you're going to be notified and given time to come into compliance. If non-compliance continues, you would receive a letter, a notice of non-compliance requesting a corrective action plan, and they will require a plan for coming into compliance. And then if the RO participant still does not come into compliance, they do jeopardize their qualifying APM participant status. And they just state that CMS has legal authority to discontinue data sharing, recoup model-specific payments, and reduce or eliminate model-specific payment otherwise owed to the participant. So here is a timeline of the requirements. Everything with a star behind it is optional in year 1, so you don't need to worry about in year 1. The only things that you're really going to need to worry about in year 1 is going to be your certification, which is due in the ROPE portal 30 days prior to the start of the performance year. The review of the IPL, which is do in the portal at the end of the summer, and then your billing requirements, which is just submitting those claims with the V1 and the V2 modifier. So this is just another way to look at the timeline across the next 3 years for only the clinical data elements and the quality submission. You'll notice that the left side is your optional stuff, and then the right side is required. So your first required submission for clinical data elements is going to be July 31st of 2023. And this is going to be for episodes from January through June of 2023. And then your first quality submission is going to be due in March 31st of 2024. So the performance year starts in January 1st, 2022, and it's going to end in December 31st of 2026, the whole model, testing. So it's going to be 5 years. One thing to note about the last performance year, no new radiation therapy episodes should begin after October 3rd, 2026. So everything that you bill after October 3rd, 2026 would have to be billed with fee-for-service because they want to make sure that it's all completed by December 31st. Okay, so quality measures and clinical data elements. So as I mentioned before, the RO model does qualify as an advanced alternative payment model and a merit-based incentive payment system, APM. And these types of models do require that quality is attached to payment. So quality measures are only going to be required of your professional and your dual participants. It's like I said in the previous slide, it's going to be optional in performance year 1, and then it's going to be required performance year 2 through 5. Quality measures will be submitted annually on March 31st for the previous performance year, so only once a year. You have to have at least 20 eligible cases for each given measure. So if you do not have at least 20 eligible cases for a given measure, you do not need to report on that quality measure. And quality measures are reported on all patients. So just to clarify, quality measures are reported on all patients who meet the inclusion criteria for that specific measure. It's not only for the specific cancers that are included in the RO model. And it's not even only Medicare patients. It's all patients that are seeing the provider that meet inclusion criteria. And then your quality measures will be submitted through the RO model's secure data portal. So let's look at what quality measures are going to be required. The first one is your preventative care and screening of depression and follow-up plan. So if the patients are going to be screened for depression, and if it's positive, you should have a follow-up plan documented. Next is the advanced care plan. And this is patients 65 and older with an advanced care plan or a refusal to complete an advanced care plan documented in the medical record. Third is your oncology, medical, and radiation plan of care for pain. This is patients undergoing chemotherapy or radiation therapy with moderate to severe pain for whom there's a documented plan within the first 2 visits. And then number 4 is your treatment summary communication and patients who undergo external beam radiation therapy and have a documented treatment summary and communicate it to the patient and to the physician providing continuing care. So that's the referring physician. So the last one is, it won't be applicable until performance year 3, but it's the CAPS Cancer Survey. And this is going to be patient experience, your payment based on patient experience. So just one thing to note is that this is going to be performed by CMS. They are going to perform the survey. This is not something you need to go out and get a vendor to do. just an example of how quality measures are going to work. So you're going to have a numerator and a denominator. So an example would be, let's take the plan of care for pain. So the numerator would be the patients who are undergoing cancer treatment, have pain, and have a plan of care for that pain. Then your denominator would be all the patients who are undergoing treatment and have pain. So your numerator is the ones who have done a plan of care. Okay, so how will performance be connected to payment? Well, CMS is going to connect the quality to the payment using an aggregate quality score, AQS, and it's based on things. So it's going to be based on your performance on the quality measures compared to quality performance benchmarks that are national benchmarks. It's going to be based on if you submitted what you were supposed to for the quality measures that are just paid for reporting, which is the treatment summary quality measure. That's the only one that is paid for reporting. So you get 100% just if you submit it. And then it's also based on reporting of clinical data elements on the oral beneficiaries. So, which we'll talk about next. So just to give you a little example of how they are going to calculate these payments. So you are going to have your quality measures. You're going to get some points based on quality measures. You're going to get points based on your clinical data elements. And then they're going to divide that by 100 and multiply it by the quality withhold, which is 2.0. And so in this example, if you look at the bottom, this participant they earned 33.3 quality measure points plus 50 clinical data elements points. And that was divided by 100 and then times by 2.0. So they will earn back 1.67% of the 2.0% quality. So now let's look at the clinical data elements that need to be submitted. So these are only required of professional and dual participants, optional in performance year 1, but required 2 through 5. So you're going to begin collecting these in January 2023, and your first submission is going to be in July of 2023. This is only for specific cancer types. It's going to be breast, prostate, lung, bone metastasis, and brain metastasis. So it's going to be 100%. You have to submit 100% of the clinical data elements on at least 95% of the patients who are meet the different cancer types. So this will also be submitted by the oral model secure data portal, and this will be factored into your aggregate quality score based on pay for reporting. So here are some examples of some of the clinical data elements that you would be expected to provide. And there are more, but this just kind of gives a summary of the types of things you'll see. So the cancer stage, histology, treatment intent, and specific treatment plan information. So here is just showing you kind of a roadmap of how to submit everything. So for your clinical data elements, there is an Excel workbook that CMS provided through the portal, and you will actually have to go in and there's templates for each cancer type. You will actually have to go in and manually input the information, which I know is going to be very time consuming, but one thing that they did state is that they are working with EHR vendors on a way to automate this procedure, because they realize that manually entering it into a workbook is going to take too long. One thing that they did recommend, if they don't get to that point before it's due, is that you could build a template into your EHR and then output that, export it into the portal. So it could be something that automatically fills in your EHR and is part of the record. And then you could just export that. That would probably be a quicker way to do it. And then for quality measures, there's a quality measure page within the portal, and you're going to just put your totals, your numerators and your denominators in there. And then I have the links on the side on how to access the portals and how to use them. So throughout this whole process, CMS will be evaluating this model. And the way they're going to evaluate it is through surveys, interviews, site visits, and any other activity needed to do a comprehensive evaluation. And they will release an annual evaluation report with their findings. So be on the lookout for that. That's all I have to say about that, but I just wanted to say that I wanted to take a moment to introduce VitalWare if you're new here, and just to let you know that we offer products to help facilities' revenue processes to be more efficient. We work hard for our clients to help them succeed, and we take great effort in staying up to date with the latest content and rules and regulation to assist our clients. So you can find more information on vitalware.com. All right, thank you. We have a few minutes for questions.
Awesome, thanks. It might be easier, Mickey, if you just open the Q&A panel and read them.
Okay.
And if we don't have time for all of them, like I said, we can put together a Q&A document and post that on our website.
Yes, definitely.
So we'll just get through what we can today.
Okay. So first one says, CMS indicates that we should submit an encounter-like no-pay claim for services that are provided during the treatment plan. What is an encounter-like no-pay claim? Does CMS want us to submit zero-fee claims for the bundled services that we provide on regular claim forms? Yes. So an encounter-like no-pay claim is going to be, you're going to submit all the same codes and everything that you typically would, same card, everything, but it will be on a zero-fee claim. It will be on a regular claim form, but it's going to be, they're going to recognize it as an encounter claim rather than that you're expecting to pay for that. So that is an area that I have not actually seen which claims need to be used, but they do have very detailed information on the website. And they actually, I want to say that there were actually pictures of which claims to use with which. So I would definitely look further into that. And I can do a little more research on that to provide on our question and answer form that we're going to send out. Let's see, is it possible that a professional would be included, but not the facility in the RO model? So it depends on where the facility, so if the professional is practicing at a facility that's not at one of the listed zip codes, that facility would not be included. So I guess in this instance, the professional, if they are sending patients to different facilities to get radiation therapy, or if they work at a radiation therapy center and for some reason send a patient to another facility, outpatient department to get their services, then if that place that they are sending them is not in the zip code, then that technical piece would not be billed using the RO model. So I hope that clarifies. I can further clarify that in the question and answer as well, but it is possible. Please confirm billing of a no-pay claim. Are there any special billing modifiers, or do we bill as we currently bill? So as far as I have seen, it's billing as you currently bill, but I do need to look into if there's a special billing modifier, because I would think there would be. I just do not recall seeing anything about that. So I'm definitely going to put something together on the question and answer to further specify that for y'all. So will this RO model be effective in 2022 or pushed back to 2024? This is effective January 1st, 2022. It's just that, so the billing is required in January 1st, 2022. It's just that the actual quality measures and clinical indicators that need to be submitted, that is not required until performance year 2. So that would not be required in 2022. But you do still need to bill using your V1 and your V2 modifiers starting January 2022. If we send a $1,500 for a bundled service with its regular charge, what denial code will CMS use to indicate there is no payment for the service that is bundled into the R model? If we send a $1,500 for a bundled service with its regular charge, what denial code will CMS use to indicate there is no payment for this service that is bundled into the R model? I am not sure about this. I'm going to have to look more into this one. I can definitely do that. If a patient declines participation, what are the steps after that? Can they keep seeing the provider? A patient cannot decline participation in the model. They can decline for their claims data to be viewed, but they cannot, they have to participate if they see that provider. Their only option is to see another provider. And I'm definitely gonna include more information on that because I do remember them specifically talking about that.
And I don't want to cut you off, Mickey, so sorry. But what was that?
We can wrap it up now if you want. There's like 2 more, but I can answer them on the handout that we send out.
Yeah, let's go ahead and do that.
Okay.
I know a lot of people have to go at the top of the hour. So
yeah.
Just a reminder to everyone, an email will be sent out by end of day today with the CEU certificates and a link to the recording and slide deck. The slide deck is actually up right now, so you can go grab that from our website. And if you don't receive any of that by tomorrow, just shoot us an email and don't forget to register for our next 2 upcoming webinars. Thank you everyone for joining us today, and thanks Mickey for a great presentation.
Thanks.
Yeah, thanks everyone. Bye.